Hello, this is Sarah, and I will be presenting on the ecological model today. This model is also referred to as the Ecological Model of Occupation or the Ecology of Human Performance Model, also abbreviated EHP. Ecology is defined as the interactions between a person and their surrounding context. Context is the main focus of this model as it looks into the relationship between the individual and their environment. Because the client is the center of treatment and the contexts that surround them are the main focus, it became known as the ecological model. The EHP model acknowledges that occupations are achieved when the personal and environmental context factors come together to make a task meaningful for that person. The EHP is a unique model that includes intervention options for therapists to use and determine which routes to take in intervention with their patients. It narrows the spectrum of opportunities that the intervention is focused on and for the client and their needs. So the EHP was created by Winnie Dunn and her colleagues from the University of Kansas Medical Center. It has now become the basis of the curriculum for the OT department at the University of Kansas. It also now guides their courses and research at the university. Dunn's purpose for developing the model was not only for occupational therapists to use in practice, but also counselors, special education teachers, and rehabilitation specialists. She wanted them to use them too. She saw how people, particularly those with intellectual and physical disabilities, were being impacted by their environments, since these settings were restricting the clients and not capitalizing on their strengths. Winnie Dunn and her team decided that there needs to be a model for professionals to use to help their clients succeed. They also decided that the model should be used in a more interprofessional manner, since interprofessionalism is what supports a patient. It is never just one type of professional working with their patient. There's always many who are there servicing them. Since Dunn worked primarily with special education in her first fieldwork job, she saw the need for collaboration among professionals as they worked together to target their patients' needs. Moreover, Dunn decided it would be best to come up with a model that supports the current trends in therapy, specifically one that is turning away from just specifically symptom management and rather moving towards increasing the patient's overall quality of life as well as allowing them to make personal choices. This quote is taken from the Cole and Tufano text on page 422. I chose to include it in this presentation because of how it represents Dunn's reasoning behind the need for this model and how it is intended to be used by occupational therapists. It reads, "This model reflects my focus on strengths, the neutrality of a person's characteristics, and a focus on the good work that occupational therapists do when they adapt, modify, and alter activities and contexts to support people in the lives they want to live." Dunn began working in a separated special education school where she saw that many of her clients were being restricted based on their disabilities. For example, they were segregated from the main public school. No one was looking into what they were capable of and working from there. They were just being restricted by their physical or intellectual disabilities. They were not being considered what their strengths were or any other capabilities that they have. She decided that there was a need to start taking a person and their strengths into consideration and then looking into their surrounding environment to see what was enabling them. By doing so, she could see what in the environment would help them and what would be restricting to them. By doing this, she wanted a model that would be centered around a client's strengths rather than being limited by their weaknesses, as many children in segregated special education schools were at the time. The Hinojosa text does a good job at describing the similarities between the EHP and various other models that it is similar to or that its concept sounds like. The EHP is similar to the PEOP model, Nelson's view of therapeutic occupation, and the occupational adaptation, since all of these consider how their individual interacts with their environment and how this relates to their occupational performance. However, the main difference between these three models and the EHP model is the specific terminology that the EHP uses. The EHP model does not use occupation as the main construct since it was not designed to be utilized only by occupational therapists. Task is a term that is emphasized in this model as it is a more widely recognized term and allows for different disciplinaries to apply it to their clients' activities in their sessions. Unlike other models, the EHP model incorporates how therapists can use different intervention options to guide their treatment plan for their individual patients. The four constructs of the EHP model are person, context, task, and performance. The person is the one seeking the treatment. They are unique in their own ways, and they are composed of their own individualized factors. These factors can include sensory motor, cognitive, psychosocial, their past interests, or their past experiences. These factors are constantly changing for the person. The context is a set of personalized, interrelated conditions that surround a person. Everything that surrounds a person is organized in a temporal way. The context includes chronological age, developmental stage, life cycle stage, health status. These are all because these factors are given more meaning by the culture and society the person belongs to. Like the person construct, these context factors are constantly changing, and the context is considered the most important aspect of this model. The person and context also cannot be separated in this model since they're constantly changing for that individual and because they are so intertwined. Tasks are considered objective behaviors that allow a person to complete an ultimate goal. There is, according to the Hinojosa text, an unlimited number of tasks that an individual can participate in. The same text uses the example of brushing teeth, where for someone to brush their teeth, it can be broken down into various tasks. These include grabbing the toothpaste, unscrewing the cap of the toothpaste, grabbing the toothbrush, squeezing the toothpaste onto the toothbrush, bringing the toothbrush into the mouth, moving it back and forth motion across the teeth, etc. Moreover, in this infinite number of tasks that a person could participate in or potentially participate in, it depends on what they prioritize and maybe what their roles are. However, a task is ultimately determined by the person's factors and context factors that surround them due to what is accessible to them and what is practical for them to do, like what they are capable of actually doing. For example, a task of making the bed includes moving the pillow, pulling the sheets up, pulling the blanket up, fluffing the pillows, placing the pillows back down on the bed, etc. For this may be a task of a mother or a nurse who needs to make a bed for their patient. But again, it is something that is influenced by a person's priorities, their interests, and their roles. Then there is performance. Performance is defined as the process and results of a person's participation with tasks and the context that surround them. When in a natural, comfortable context, performance will look a lot differently than when a person is in an artificial context, something that is not of their usual context. This performance construct is gauged by performance range of the individual. This is something that is described as a person's ability to complete various types of tasks based on their personal factors. It also compares it to a range of tasks that a typical person can do. So one's personal performance range is going to be different than like the model typical performance range. In addition, it encompasses the person, context, and the task. The range includes meaningful tasks, again, that are available to a person based on their personal and contextual factors. Lastly, performance is easily affected by the other constructs since it is based off of the context surrounding a person, the person's abilities, and their tasks that they hope to accomplish. This figure was taken from the Hinojosa text on page 213. This is just kind of pointing out each of the constructs of the model. The person is at the center of the context, since the context is everything that surrounds a person. The T's are representing all of the various tasks that a person could potentially participate in. The performance is at the end on the right-hand side of the tasks because it is the result of the person interacting with their context and ultimately engaging in their tasks to complete the performance of that task. This figure is also taken from the Hinojosa book on page 213. There's also one in the cold text. It's just colored differently. But this time, this figure is including the performance range of a typical person. I just want you to notice and note how the performance range is wider in this figure. We are going to compare that to two other figures in just a moment. This figure is composed of all of the constructs, the four constructs: person, context, task, and performance. In this figure, there is a little cone shape within the context, and this is representing a person evaluating their context to determine the task that they are available to them. Then the larger cone shape on the outside of the context, it is going through the various tasks, and that is the performance range. So the performance range is an expansion of the person, context, and tasks as it's running through it. It is what range of tasks would be available to that person. Again, this figure is taken from the Hinojosa text on page 214. This one is a little different because it is explaining how people have unique roles, and within these roles it contains different tasks, some of which are intertwined. As you can see, there's two T's that are kind of in the two bubbles. It also shows that tasks can be categorized based on these roles that a person has or wants to participate in. So these are the two figures that I was referring to from the Hinojosa text, page 215, that I had mentioned to pay attention to the narrower performance ranges. In figure 9.5, there's a typical size person and context bubble. However, the performance range is smaller because it is showing that it can be affected by a person's abilities. The context bubble remains the same size because in this example, the context is not being affected. It is still supportive to the person, but their abilities and skills do not allow them to take advantage of the context, which in turn affects their abilities to ultimately participate in tasks and complete these tasks, so perform out these tasks. An example that the book gave was that a person may have a macular degeneration and they cannot read their mail despite the fact that the print on the mail is pretty large and they are sitting in a well-lit area. So now for the other figure, 9.6, on page 215 of the Hinojosa text, is representing the idea that the person's context is the one that is being affected this time. It's the one that is diminished. When they have less access to the resources to effectively carry out tasks, and which is directly affecting their performance range. This is despite the fact that they actually are capable of and do have interest in participating in these tasks, but because the context is smaller, is diminished, they don't have access to a lot of resources, they cannot carry out a certain number of tasks, so therefore their performance range is smaller. This final figure that I'll show you from the Hinojosa text is on page 216. It is explaining how the therapeutic interventions are affecting each component of the model. Intervention options are included in this model, and they are part of what makes this model unique. There are 5 intervention approaches. First is the establish/restore. This is also sometimes called remediation. It is directed at changes in the person to improve their skills or establish new ones. This intervention does consider context, even though it is mainly focused on the person. It considers context because the context will determine the task available to the person, as well as give support to their performance by providing them with necessary resources to complete these tasks. Second is adapt/modify. This intervention strategy targets context and task. This is when a therapist may have to make adjustments to certain aspects of the context or features of the task to make it more attainable for the patient. The therapist may have to modify the thickness of a coloring utensil, for example, for a child with lower fine motor skills. The third is alter. This intervention approach targets context. Therapists will take inventory on a person's interests and overall skills, and then work to alter their context around them so that they can actually utilize their skills. Or it may just be altering one's social circle if it is not a supportive one. For example, if a person has an alcohol use disorder, providing them with a more structured, supportive group of people rather than maybe their current situation. Another example may just be helping a person find a 1-story house compared to a 2-story house or more for someone who just had their leg amputated and can't reach the other stories. The fourth intervention is prevent. This intervention addresses the person, context, and task, but also it takes place before a problem occurs or even if a problem doesn't exist yet. An example of this would be if a parent has a child who keeps wetting their bed, stop giving them water 2 hours before bedtime, or having them use the bathroom right before going to bed to prevent this bedwetting accident. The last intervention is create, and this is addressing the person, context, and task. This is also geared towards all types of people, not just specifically the patient. The goal of this type of intervention is to create situations that will ensure patients' maximum performance. This includes, for example, a universal design playground that is handicap accessible, interactive, and stimulating, and has components for various cognitive abilities, and it's also fun for children of various ages. So to summarize, these intervention strategies help OTs not focus so much on fixing their client, but consider all aspects of who their client is and their environment that surrounds them to support them. These 5 interventions also help the OT choose from various service modes like settings that are community-based, consumer-driven, and health promotion values and practices are at the head of their focus. These intervention strategies can also be tailored to more people because there are more options to choose from and there's no one specific mold that they have to fit into. So they can be chosen and then structured to specific individual needs. So applying the EHP in therapy. When a person's factors are stable, context factors are the ones that the therapist needs to target for intervention. This model does require a lot of planning to structure the evaluation before seeing a patient, and then there must be structure while in the process of evaluating and then in the intervention process. Therapists must incorporate all constructs, person, context, and task that are then going to affect the patient's overall performance. The Hinojosa text lists some basic steps that are utilized by the therapist when following the EHP model. Number 1 is the therapist must identify the person's interests, wants, and needs, and then organize them based on importance. 2 is the therapist must understand a person's prioritized tasks that they have listed in order to understand which route they will be taking in intervention. 3 is the therapist then needs to evaluate how the person's performance in these tasks varies from the norm. So number 4, after they will be evaluating the context to see what may be affecting their performance of these prioritized tasks. Number 5 is the therapist must then evaluate a person's individualized factors and determine which may positively or negatively be affecting a person. Lastly, 6 is the therapist needs to develop intervention strategies that will ultimately enable the patient to participate in their prioritized tasks and have the context be supportive for them to reach these goals. So here is an article that I found that used the EHP. It was called The Application of the Ecology of Human Performance in Cardiac Occupational Therapy, a case study. This study focused on cardiac rehabilitation and the OT's role in working with their patients. The author stated how cardiovascular disease is a leading killer among the population. It has a large variety of negative effects on people who are living with this disease. And the article also details how there really isn't much research in the ways that OTs can implement this EHP model into their practice while in a cardiac rehabilitation setting. The article includes, from the best of their knowledge, they are actually the first study to use the EHP to see if it improves cardiovascular health. The authors added that there needs to be more research on how OTs can improve the lives of their cardiovascular rehab patients, since right now there really isn't that much information on the topic. That is why the study was significant to OTs and their use of the EHP model to help their cardiac rehab clientele. The study followed a 50-year-old man who was living with cardiovascular disease. His research was done via evaluating this man as he was treated at home by his OTs. The OTs interviewed the man and his family to gather information on his role and priority goals. These priority tasks that he hoped to be more independently or perform more independently on his own were toileting, bathing, and praying. The OT created an intervention plan for the client by increasing his physical activity to enhance his abilities, as well as they advised him and his family to take make some more environmental and lifestyle adjustments. The OTs guided this procedure. They also used the COPM scale to figure out which specific activities he valued and prioritized, and that is what they would be working with. The scale was also used after intervention to see if he was satisfied and if the satisfaction increased. The results of the study revealed the EHP model did improve the man's performance in task and his satisfaction with the performance. Moreover, he felt that he was able to be more independent after the EHP intervention and the occupational therapist's help. The OTs and the client found that this model used a more holistic approach, and both parties liked this. In addition, they found that making the environment around the client a main factor of the intervention was very important. So this table was taken directly from the third page of the article. I chose to include this table because it perfectly summarizes each step that the OT took in the different intervention strategies. The EHP model framework states that when using the model for intervention, not all of these options for intervention need to be acted upon. However, by utilizing all 5 intervention strategies, the client is getting a more detailed care. And here is my discussion question. And here's the reference page.